All right, so we're going to go into the shocks. So what actually classifies shock? What is shock? Decreased tissue perfusion, right? So essentially that's all it is a syndrome of some sort of decreased tissue perfusion, right? But because of the decreased tissue perfusion, we also get impaired cellular metabolism. So normally, we have aerobic metabolism. It sends our body into like an anaerobic metabolism. So that's when you start producing that toxic buildup of the lactic acid. So when we talk about the diagnostic studies, this is going to be for, see at the top it says all types of shock. So I kind of went with the book with this where it's going to be like all types of shock, and then we'll talk about specific to each type, and then we'll do like collaborative care for all types and then specific to each type. So it kind of jumps back and forth. It's not as concise as these. And that's why I said if you made yourself one of these either before and took notes, but then you'd have to flip back and forth. But maybe like later, if you listen to it again, you can go back and forth to your papers and make yourself one of these. It'll just be more concise and all in one spot. So when we talk about diagnostic studies, you guys pretty much talked about how there's no really concise, like this test will tell you that the patient has cardiogenic shock, right? Or this test will tell you the patient has septic shock. So there's no single blood study out there that's going to tell you that the patient has shock. But some of the things that we are going to do is we're going to look at the H&P for our patient, because we know that certain patients are going to be at higher risk for the shocks. We need to make sure that we get a good past medical history, past surgical history, that we get a good history of recent events. So the last few weeks, what's been going on. Almost always, one of the big tests that we're going to get is that lactate level. And most of the time, they're going to have that increased lactate level secondary to that anaerobic metabolism. How do we usually get rid of lactate, lactic acid? Elimination through where?
Urine.
So most of the time, it's going to be picked up through the blood and then filtered out through the liver. But usually, at the same time, we have these patients now that are in some sort of shock, so their liver is not being perfused well enough, so it can't clear that lactic acid, and that's why you're going to get the increased lactate levels. We're going to look at the ABGs, ECGs, chest x-rays. Anytime you have a patient that is in shock, they're going to be in the ICU, right? And they're going to have some sort of arterial line that we're going to be using for the hemodynamic monitoring. So cardiogenic shock, where's our cardiogenic? Over here. They talked about how it can be systolic or diastolic dysfunction. So systolic would be like the inability to pump the blood forward. Usually it's something to do with the left ventricle. So MI is the biggest cause of it. Blunt injury, hypertension. And then our diastolic dysfunction, which would be like your tamponade or your ventricular hypertrophy, cardiomyopathy. Specific diagnostics would be your echo, your EKG, the troponins. Other things that we'll also get, lactate level, ABGs, BNPs, glucose, BUN. So when we talk about manifestations, we have early versus like what it's going to turn into. So the early manifestations are going to be that increased heart rate, decreased blood pressure with a decreased cardiac output. So you'll have decreased cardiac output if you have the cardiogenic shock. And the narrowed pulse pressure. They'll also have increased respiratory rate, crackles, cool clammy skin, decreased capillary refill, anxiety, confusion, agitation. And remember we talked about the decreased urine output. Secondary to that decreased renal perfusion. So basically a person going into cardiac shock is going to kind of look like someone in heart failure, right? So they have the crackles, the decreased cap refill, the pallor. Mortality rate's about 60%. And then, I know that you guys put it up here somewhere. It's the #1 cause, there it is, leading cause of death from acute MI, cardiogenic shock. So basically, anytime we talk about any of the shocks, it's going to be either a problem with the pump, right, your heart, or a problem with the pipes, so your veins and arteries, or with whatever's flowing through the pipes, your blood. So when we talk about like hypovolemic. So cardiogenic shock, there's a problem with the pump. Hypovolemic shock. Oh, I didn't have anybody do hypovolemic shock. We missed hypovolemic shock. I know. What are we going to do? All right, so causes. We have absolute versus relative. What's the difference?
One is absolute for sure, and one is maybe.
The water's gone from the body.
Thank you. So absolute.
The water's completely gone.
One of vodka?
The absolute means that the fluid is gone, right? There's no getting it back. So they've either been vomiting or pooping or bleeding, or we have lots of old frail people down here, maybe just sweating it all out even. So that's absolute. So loss of intravascular fluid volume, secondary to hemorrhage, burns, diabetes insipidus, diarrhea. And then we have relative. So what do you think, if that's absolute, what's relative? Third spacing, right. So the response to acute volume loss is going to depend on the amount lost, right? The kind of injury it is, the person's age and health, and how well they can compensate. So losing about up to 15% of your body volume, your body's going to be able to compensate. You might not even notice it. Anything from 15 to 30%, you're going to have some sort of SNS response going on. So you're going to have that increased heart rate. You know, your body's going to be compensating. You're going to notice the compensation. Anything greater than 40%, your body can't compensate anymore. So they're really going to start going down. You guys do not need to know the stages. In your book, there's stages of shock. You do not need to know that. It's not in your objectives. So diagnostics for hypovolemic shock, what do you think we're looking at? Electrolytes, hemoglobin and hematocrit, definitely. Lactate, ABGs, good. So you know how when we say neurogenic shock, think bradycardia? So hypovolemic shock, think weak, thready pulse. So your patient, the manifestations, weak, thready pulse. They're going to be anxious. They're going to have some tachypnea. Remember, we have fluid volume deficit, so we have decreased cardiac output. But what's your heart doing to try and compensate for the decreased cardiac output?
Raising the heart rate.
Pumping, right? So you have increased heart rate. Because of the fluid volume, your body's trying to hold on, so you're going to have decreased urine output. So neurogenic, you guys did a good job over here because we have pretty much everything except for under spinal cord injury. It should say anything higher, T5 or higher. So above T5. So causes spinal cord injury above T5. And I know Audio said it can occur within 30 minutes and last up to 6 weeks. Other causes would be that spinal anesthesia or the opiates and benzos, which he also has up there. So remember, this is massive vasodilation secondary to loss of the SNS, right? So the picture that she had was perfect. Basically the veins and arteries, they're getting all floppy. And I liked that you used the word floppy because that's the word I always use for it. So they get floppy. So they're not pushing, but you don't have that systemic vascular resistance helping the blood back around where it needs to be. So it's not getting to the organs the way it should. So you're going to have decreased organ perfusion. And it's not getting back to the heart to pump it back out. So you're going to have decreased cardiac output. Remember, the big thing with this guy is the bradycardia. The poikilothermia, so that's where your patient's not adjusting the body temperature itself. So it adjusts to the room temperature. So we need to make sure that we're, either kicking the temperature of the room down to where we need it to, or up, depending on where you are in the hospital, where you need to be, making sure that there are blankets. And then I think one of you guys also talked about how initially you're going to be warm, right? Because you have that massive dilation. So the blood is pooling. So the blood's pooling. You're going to have nice and warm arms, legs. But then because there's no auto-regulation and there's nothing moving, the heat is escaping quickly. So then they become very cool and you have that hypothermia that happens. So it's a hemodynamic phenomenon. Bless you. Back to our anaphylactic shock back there. So the causes is a hypersensitivity to some sort of substance. So whether it be a drug, chemical, vaccine, food, insect venom, the trees outside. One of my students one semester, her son had to carry an EpiPen everywhere he went because he was allergic to so many different trees in the area. If they were in bloom, that he would just go into shock. Like he had like a severe allergy to the just seasonal, I guess. So it can be through contact, inhalation, ingestion, or injection. Ingestion is what's the most likely to cause anaphylaxis. And Gladys did a really good job back there telling you exactly what happened. So basically your body, the first time that you're exposed to it, you're not going to react to it. You might get a little something, but you're not going to have the reaction of like an anaphylaxis. Your body is basically going to say, oh, I don't think I like that. And it's going to build up these IgEs. And so the next time it's exposed, instead of like kind of feeling it out and taking a little while, it's going to immediately say, oh no, that's that thing I didn't like, and you're going to have a reaction super fast. So these happen really, really, really quickly. And almost always it's the second or third time that you're exposed to it, never the first. So the manifestations, you're going to have the respiratory distress, secondary to that laryngeal edema or severe bronchospasm. You have massive vasodilation, so you're going to have circulatory failure secondary to the massive vasodilation. So these guys are going to be third spacing on you because you're going to have the increased capillary permeability. And I know back there they wrote it, they're going to have that feeling of impending doom. And your patient will say, I just feel like something really bad's going to happen. Like, this is not good. And they talked about back there too, the wheezing and the stridor that could happen, and the swelling of the lips and tongue, so that angioedema. Is every patient in anaphylaxis going to look like that though? No. Has anybody in here had a anaphylactic reaction to anything? To what? Or you don't have to tell me to what, but to bees? What happened?
I started wheezing.
You did wheeze, but did you go into an all-out respiratory failure distress?
No, I just used somebody's EpiPen.
Oh,
I
she said she used somebody's EpiPen.
I used somebody that was there.
That's smart.
Yeah.
And then you got to the hospital, and they said, you need to start carrying your own EpiPen.
Because I never had one. I never had one.
Yeah.
I didn't, but my husband did, and his face actually blew up. Like, y'all remember that movie Hitch, when he like has a reaction to the shellfish? He literally, his face started blowing up, his tongue started.
So he had like the absolute extreme.
Yeah, it was bad.
Did he end up in the hospital?
He did end up in the hospital. I shoved some Benadryl down his throat before his tongue swelled up, and we ran off to the hospital.
Yeah. Kelsey?
Mine's bathroom.
Mine too.
Yeah.
So what happened?
My throat closed up.
So mine did not. So I'm the perfect example of not that they don't all look alike, because I didn't have the wheezing, I didn't have the throat closing, I didn't have like the angioedema, although I have had angioedema from other things, not from this reaction. I took one of the antibiotics. I was in graduate school at the time, and I went home. And so I got the antibiotics at like 2. So I took one and I went home. And at like 5, I started feeling really bad. Like my fever spiked, and I just started feeling real swollen. And I thought, oh, it's not kicking in. Let me take my second dose and I'll go to sleep. So I took my second dose, and then I started like getting real woozy and dizzy and like more swollen. And I was like, maybe I should go to the hospital. Medicine's not working. And they were like, yeah, it's not a typical response, but I basically looked like the Stay Puft Marshmallow Man, but I didn't have any of the airway stuff going on. So the anaphylaxis doesn't always involve the airway. Yeah. So, good. So septic shock. And I put a little cheat sheet up at the top there for you, what I was kind of talking about back there. So when we talk about sepsis, we have that SIRS criteria plus a documented or suspected infection. So I know when I worked for HCA, I don't know how the Baycare flags it, and I don't think that Bayfront has a specific SIRS sepsis Actually, they do. They just started doing it. They have to do it once an hour, I think, or once every 2 hours. But I know when I worked for HCA, it would come up every time you did documentation. It would say, it would fill in automatically for the SIRS criteria from the last vital signs, the last WBCs that were drawn, the last vital signs with your respiratory rate, And then the question would come up and it would say, is your patient on antibiotics for an infection or prophylactically? And if you hit yes, it would throw a sepsis alert. So even if there's some sort of suspected infection, but they have no idea what it is, so they have them prophylactic, we're still going to call that sepsis. So severe sepsis, and they might be changing all of this now with the new SIRS criteria, but severe sepsis is basically sepsis plus some sort of organ dysfunction going on. So now your patient's really confused, or they have those crackles in the lungs, right? And then septic shock is what we talked about, where despite fluid resuscitation, adequate fluid resuscitation, we still cannot get that blood pressure up. So some of the risk factors for septic shock are age, either really young or really old, immunosuppression, so somebody who's maybe on chemo or on steroids, trauma, and then any of our patients with invasive lines. Doesn't that sound like most of our patients at the hospital, right? They have some sort of line. Causes. So I think your book says like 10 to 30% of the time they don't even know what the cause is. Like sometimes it's just some infection. They just can't even figure it out. They throw a whole bunch of stuff at it. They get better. But most of the time it's going to be some sort of bacteria, fungus, parasite, virus. And it's just like they said when they were presenting back there, your body just has this like exaggerated response to it. And then remember earlier when I was talking about SIRS and the inflammatory mediators that come out? I mean, that's basically what happens is you have this exaggerated response of them, your body just sending out every inflammatory mediator it has, trying to get at whatever is going on in there. And then your body just, the whole cascade starts. So as far as manifestations go, tachypnea, altered neurostatus, decreased urine output, GI dysfunction, and I think they also made a comment back there about the GI dysfunction. It can be GI bleeding, it can be a paralytic ileus. Eventually it will turn into that GI translocation if the patient's not fed or we don't get the gut moving. And a lot of the time, our septic shock patients will end up in ARDS. They also will have that increased glucose without diabetes. So you and me who normally have like an 80 fasting blood sugar will suddenly have 250. What's that?
Is that kind of related to cortisol at all? Or
no, it's more related to the liver dysfunction. Mm-hmm.
Do we know how much fluid they've tried to resuscitate with? Do you know?
So when we talk about adequate fluid resuscitation, remember I said back there it's 30 to 50 mLs per kilogram?
All right, I missed that, sorry.
That's okay. So, yeah, with these guys, we definitely need to know what adequate fluid resuscitation is. Because that's going to determine when they go from sepsis to septic shock, right?
And what time frame though? You said 30 to 50 milliliters per kilogram and what, like?
So usually if the patient is septic, they're getting it in there pretty quickly. So, I mean, if you have a
Just
patient...
like a matter of hours or something?
Yeah, we'll talk about like the sepsis bundle, and when we do, we'll talk about that.
Okay.
Okay.
I'm ahead of you.
That's okay. 3 major pathophysiological effects that could happen. So we have that vasodilation. So they're that warm shock initially. maldistribution of blood flow. We have the decreased systemic vascular resistance. And it can also cause myocardial depression. So with these patients, sometimes their ejection fraction will go way down. When we get them out of septic shock, it will return to normal. Usually over like a week to 10 days, I think your book says. Obstructive shock. So they talked about obstructive shock over there. So there's lots of things that can lead to obstructive shock, right? So as far as the causes go, it can be tamponade, constrictive pericarditis, tension pneumo, PE, aortic stenosis. So it's some sort of physical obstruction to the blood flow that decreases the cardiac output. So like Jeff said when they were up here, basically like your heart, something is causing your heart not to be able to expand enough that it's filling up. So when it goes to pump out, you're not really pumping anything out because it's not expanding enough to fill up. So some diagnostics that we might use depending on what we think is going on, or if we just really don't know. They're going to be doing all sorts of x-rays, echoes. We're going to be looking at clinical signs and symptoms like the deviated trachea. Your patient might have JVD. They might have just a generalized edema, fluid overload. They can end up with a what was I just going to say? No, compartment syndrome can be part of the reason that it could happen, like a abdominal. I think they said that when they were up here, the abdominal compartment syndrome. Because if you have the pressure pushing up, right? So you have all the pressure here pushing up, it's going to be pushing up. So your heart, again, is going to be kind of like with the tension pneumo where everything gets pushed over and the heart just can't expand.
So how do you get it out?
How do you get what out?
How do you get the too much fluid in the abdomen? How do you get it out?
So it's just going to depend on what's going on as to what you're going to do. So we'll talk about the collaborative care for them in a minute. I know. I told you this one kind of jumps around because I kind of tried to follow the book. So with these patients, we need immediate relief from whatever's going on to prevent cardiac arrest. So collaborative care, here we go. This particular slide is going to be for all shock types, and then we're going to go again into the specific shock types. So collaborative care, so general, we want to identify our at-risk patients, right? So when you have a patient that you're taking care of, that's a patient that, remember we said that these patients, especially with the septic shock, that they're older or younger, that they have invasive lines. If you have a patient that just had an MI, they're obviously at higher risk for the cardiogenic shock. So whenever you have a patient that fits that category of an at-risk patient for any of the kinds of shocks, so your spinal cord injury patient at C6, you need to be able to identify that it could eventually lead to shock and it could happen quickly. We need to make a quick diagnosis. So this is, again, why your assessment's so important, because how often are those doctors there making their diagnoses? Maybe once a day, right? If you're lucky. So you're the eyes and ears for that doctor, so you need to be able to recognize the signs and symptoms. We need to do it quickly so that we can stop the decreased perfusion. Protect the organs from dysfunction. and make sure that we're just doing supportive care. So as far as fluids go, we want to do fluid expansion, especially if you have a patient that's in septic, hypovolemic, or anaphylaxis. Those 3 shocks, we're going to be doing lots of fluid resuscitation, right? Fluid expansion.
Say it again, septic, hypovolemic.
Septic, hypovolemic, and anaphylactic. Because if you think about it, cardiogenic, it's not really fluid related, right? As a matter of fact, the heart can't pump what it has, so why would we add more? Because it's already having a hard time with what it has, right? So those are the patients, the cardiogenic patients, you want to be really careful about giving them any fluids. The fluid that we use that's our go-to gold standard is obviously the isotonic normal saline. You will see certain hospitals and doctors will use lactated ringers. Why is that kind of like iffy? So there's lactate in it, right? And if your body already can't clear the lactate that's there, it can't clear the one that you're hanging either. And it's controversial. Some people will tell you that it doesn't make any difference. Dr. Apple from the ER at Bayfront did a thing on sepsis, and maybe it wasn't her. One of them down there, and basically said that they use lactated ringers because they don't feel that it makes any difference. But for our testing purposes, we're going to say isotonic normal saline. They're going to get 2 to 3 liters pretty quickly. Depending on what's going on, they might also get blood. Nutrition, remember we want to get these guys eating quickly. So we want enteral within the first 24 hours. If for some reason they can't take enteral, then we'll go to parenteral. Or if they can't meet at least 80% of the caloric needs, we'll add parenteral. We want to make sure that we're monitoring under nutrition the protein, nitrogen, BUN, glucose, electrolytes.
They don't eat how many percent? 30% you said?
If they can't get 80% of like the
80%?
caloric need, basically, because remember these guys are sick, their body's healing, so their normal caloric intake might be 1,200, whereas now their body is trying to heal, they might need 24 or 3,000 calories, right? So if they can't take that in, because again, if you're sick, you don't want to eat, then they'll do the parenteral along with it. So we're also weighing these patients, and before we decide that they need more fluids, before we decide that they are not getting enough calories because maybe they had some weight loss, we want to make sure that we rule out dehydration. So it could be that your patient's not actually getting enough fluids. Or maybe they've gained some weight, and so now you're saying, we're giving them too many calories. But this is when you need to assess your patient because maybe they're third spacing. So maybe they actually have just gained a bunch of weight because we're giving them too much fluids and they're just third spacing on us. Drug therapy. We're going to use vasopressors. So what's the big vasopressor that we usually use? The Norepi. So that's when the hospital you'll hear them say like Levophed. Usually, but for NCLEX now we have to make sure that you guys are just generic. So the Norepi. It's horrible though, because in the hospital you'll hear a lot of the nurses still using the brand names.
Yeah.
And so I know it's very confusing. vasodilators. So if your patient has cardiogenic shock, we might need to give them a vasodilator to get their MAP greater than 65. So back to the vasopressors for a minute. So with the norepi, we're not just going to give that. We have some parameters that we want to make sure that our patient's meeting first, right? So what's the norepi going to do? Even before, like, what's the patho of it? What does it do? It's just, right, so it just is going to clamp down those veins, right? Remember your veins that are, now you've lost your systemic systemic vascular resistance. So now that's just going to bring it back. It's going to help clamp them down. So what's going to happen, though, if there's not enough going through your veins, and now we've clamped down the veins, but there's nothing for it to push forward, right? So we need to make sure that our patients have been resuscitated with fluid. So what do we want our CVP at before we give any sort of vasopressor? No, so we want our...
4 to 8. I think.
Okay, so here's the thing. So your normal, like you and me, is 2 to 8, right? Or 4 to 8. You are not going to give a vasopressor until your patient is minimum of 8. They have to be a minimum of 8 before you're going to give the vasopressor, and hopefully they're closer like 12 or 15. So we want to make sure that we have stuff in there that we're moving around. CVP is just measuring basically how hydrated your patient is, right? How much is flowing through those veins. So anytime we talk about a vasopressor, we need a CVP of at least 8. So if we start talking about a patient who's in shock and their blood pressure is low, let's say we have a patient and their blood pressure is, I don't know, 70/42. And I say, how are we going to get their blood pressure up? Fluids, right? Until we get their CVP to 8, and then we can give the vasopressors. So if I give you a patient who has low blood pressure, but their CVP is like 2 or 4, no vasopressors until the CVP is up to 8. Okay? I just said that 3 times, so it must be pretty important, right?
Can I ask a question, please?
Yeah.
The MAP, is it not supposed to be greater than 70 or 70
60,
and above?
65.
65, is that what the book says?
Mm-hmm.
Okay.
I have another question.
Yeah.
So you're saying for the CVP, for a normal healthy adult, it's 2 to 8.
Uh-huh.
But then if you're a person who's in the hospital in shock, then you want it to be at least
At
8.
least 8 before you're giving any vasopressors.
So just
Because that will tell us that we have given you enough fluids. Because if we're giving it to someone who has a CVP of 2 or 4, there's not enough in there for that to even, I mean, it's not really going to do anything. It's still not going to bring up the blood pressure because there's no blood for it to pump around. So they need the fluids or the, fluid expanders. All right, so
normal 70.
O2 and ventilation. What's our priority with every patient, whether they're in shock or dead on the side of the road? Airway. So we want to make sure our patient has a patent airway. Always our first priority, no matter what's going on with our patient, because nothing else matters if they're not breathing, right? So we want to maximize our O2. So we want them want them to have an SpO2 greater than 90. Although in the hospital, most of your doctor's orders are going to say keep it above 92, right? I think the book, though, says 90. We want our PaO2 greater than 60. And that is, we'll go further into the PaO2 next week with the ARDS, because that's going to be a big indicator as to whether or not that ARDS patient is doing well, the PaO2 greater than 60. We might have to get them onto a ventilator if we can't keep them up. And then these are the guys, remember earlier I said we want to space out their care to kind of to maximize their O2 consumption. So if they need a bed bath, we're going to do it and then maybe not go in for another little while before we go in and maybe do like their trach care and suctioning, right? Yeah. And then maybe wait a little bit longer even before we go in to do repositioning changes. So we're just going to make sure we space it out so that we're increasing the oxygen they can get and that they have. All right, so collaborative care is specific to cardiogenic shock. We want to restore the oxygen supply and demand balance. So basically, with any of our shocks, we have this imbalance. We're not getting enough oxygen to for the supply demand, right? So we need to restore the blood flow to the myocardium and increase that cardiac output. They made the list up here for us, so they might go in for cardiac catheterization. They might end up with angioplasty with stenting, emergency revascularization. If it's secondary to a valve, they might go into a valve replacement. Remember we talked about the circulatory assist device and the intra-aortic balloon pump. Those are going to decrease the workload of the heart. In very rare instances, we have people who are in like a chronic cardiogenic shock, and they will end up having a cardiac transplant, a heart transplant. It's really rare though. As far as drug therapy goes, we might have to give diuretics to decrease the preload. Again, those nitrates, because they're going to decrease the workload of the heart by dilating those coronary arteries. So our collaborative care is specific to septic shock. Oh, did I miss one? Hypovolemic shock. My finger hit it twice. Hypovolemic shock. Basically, it's going to depend on what's going on with your patient, right? So if there's fluid loss, we want to stop the fluid loss. We want to restore circulating volume. So that's our primary goal, basically, with the hypovolemic shock patient. Stop the loss of the fluid, restore the circulating volume. So the rule that your book talks about is the 3-to-1 rule. So for every 1 ml of blood or estimated blood loss, they're going to get 3 mLs of an isotonic solution. So let's say your patient lost an estimated 100 cc's of blood. They're going to give them 300 cc's of normal saline. Okay? So they're obviously getting IV fluids. They might be getting blood if it's blood loss. We're going to be giving them pressors to get that blood moving. If they're bleeding, we might be giving them, remember we talked about the fresh frozen plasma with the what? We might be giving them platelets, but remember the fresh frozen plasma has the clotting factors. Thank you. Or they might need to go to surgery. Let's say it's somebody who was stabbed or a gunshot wound and they're internally bleeding. They might have to take them to surgery to stop the bleeding, and then they're also going to be doing the fluids in the blood and the FFP. So again, with the hypovolemic shock patient, it's really depending on exactly what's going on. If it's a patient who really has plenty of fluid in their body, they're just third spaced, so that's your relative, right? Relative hypovolemic shock. You'll be giving them like albumin to pull it back in, and then you're going to have to figure out what's going on, why it's happening, and try and fix that underlying cause. Good. All right. Septic shock. This guy's a big one. What did we say we want our CVP at?
8 to 12.
8 to 12. Minimum of 8. Minimum of 8. Really, if you just remember minimum of 8, you're good. So I think 67, is it chapter 67 that has the shocks? No, 66. Let's see, it was 67.4, so let's see. 66.4? No.
66.
No, I was looking for if they had the bundle in here somewhere. I'll
The
talk
what?
about it though. The sepsis alert protocol. That's all right, we'll talk about it. So remember these guys, they're going to be getting plenty of fluids. We want to restore the perfusion. That CVP has to be at least 8. These guys might be getting 10 liters of fluid before you're getting them up where they need to be, right? We're going to be giving them those vasopressors once the CVP is greater than 8. And again, that's that norepinephrine. Might be giving them dopamine. What's dopamine do? Yeah, it's going to increase the contractility and the blood pressure. So if you have a patient who can't maintain adequate blood pressure, even with the vasopressors, then they'll add in those IV corticosteroids. And I know that you guys had that written on your thing back there, but I just wanted to make sure you knew that the IV corticosteroids usually is used if the vasopressors get them up but not up high enough. Then they add in the corticosteroids. We want their MAP greater than 65. We want their lactate levels back to a normal level. And hopefully all this fluid that we're pushing is helping to flush that lactate out, right? So we call these the endpoints of fluid resuscitation. Endpoints of fluid resuscitation. And we used to ask that question on the test every semester. And every semester, even though I stood up here and I said, y'all need to know your endpoints of fluid resuscitation, and this is them. And I would go, and I'd say it 4 times. Every semester we had to throw the question out, and I'm not sure why. So I'm going to tell you it. I don't think we're asking it this semester, but you should know them anyway. So endpoints of fluid resuscitation, meaning that your patient has enough fluid on board. So their MAP is back up at 65. Their lactate levels have normalized. We have flushed enough that we've gotten everything working the way it should. And I know that the urine output, you guys are used to saying how much? 30, right? So this is critical care. So the urine output, no. The urine output is greater than or equal to 0.5 mLs per kilogram per hour. Seriously. So because with these patients, like every little ml is going to count. These guys have organs shutting down. So the only way that we're able to keep track, these are your very strict I's and O's. Like every hour you're measuring output versus intake.
So half your body weight in kilograms.
So 0.5 mLs per kilogram per hour. Yeah.
Normal lactate level.
The normal lactate level, I believe, is less than, I think it's 2.4. It depends. No, it's not. I lied. Hold on. It depends on the hospital, but I think anything less than 2. Does your book have a normal lactate level in there? Because I think we've done this before, and we talked about the book versus what the hospital is, because we've pulled in what the different hospital ones are. It just says increased, right?
Yes.
And that's really all you need to know is we're not going to give you numbers. And at your specific hospital, when you get that lactate level back, it's going to say if it's high or low. Because I think that depending on the hospital and the tests that they run, it's going to be different. The urine output, 0.5 mLs per kilogram per hour. And we want their CVP up.
So the CVP at 8.
8.
And what about the glucose?
We want the glucose levels below 180. Remember we talked about that earlier? We want them below 180. And I don't think your book says that they don't want them too low. But, it does actually, because I wrote it in here, so I know that your book probably does, or maybe it was the 9th edition that did. But they basically say they want it above 110, because anything lower than that, and I don't know the dynamics patho to it, but it actually increased mortality in all the tests that they did. So they basically want it between 110 and 180.
We did talk about that.
I think someone's trying to get in and the door is locked. Do you want to just pop the door open for her? So with these guys, we want them on H2 blockers to prevent stress ulcers. We want them on DVT prophylaxis. So like our low molecular weight heparin, so the enoxaparin that we give, the Lovenox.
No, below.
But remember, you need to know the generic, so it's enoxaparin.
Oh, it's not so. Okay.
Yes. Broad spectrum antibiotics are going to be given. So when we talk about our sepsis protocol, and every hospital is a little bit different right now because I think they're all in the midst of changing. I know one of them has like a 3-hour bundle, one of them has a 2-hour bundle. But for testing purposes, we're going to say that your patient comes in and we suspect some sort of septic shock, right? We know that there's something going on infection-wise. The very first thing we're going to do, after obviously the patent airway and getting the IVs, is going to be that we are going to basically swab everything and anything. If they have any sort of wounds, we're swabbing it. We're going to get a urine sample. We're going to get a sputum sample if we can. We're going to get blood cultures. It needs to be done quickly because basically you have 1 hour to get broad spectrum antibiotics hanging. So before you can hang those, you're going to get all those cultures. You can't get the cultures after the antibiotics have started. So broad spectrum antibiotics, usually they're going to be hanging like, Vanco and Zosyn. And then they're going to hopefully get those cultures back within 24 hours because that's about what it takes, 24 to 48 hours. But usually they'll start coming back. And they're going to kind of narrow it down because they're going to be doing the sensitivity at the same time. So if it comes back that it's something that is susceptible to amoxicillin, I don't know, then they're going to take it and they're going to go from that broad spectrum antibiotic down to whatever antibiotic is actually like the lowest that they can do for that one. And that's basically like to try and prevent the superbugs, right? Mm-hmm. So once the actual organism is identified, then they'll give those specific antibiotics that they need to give.
Do we give antibiotic before fluids?
The fluids are going to be hung pretty quickly. So,
Okay.
I mean, the fluids are going to be hung before. You have an hour to get the antibiotic hanging.
Okay.
So you're already going to have fluids hanging on these patients because that's going to be one of the very first things. You're just going to probably have an open bolus hanging.
Okay.
So. Did I hit everything that was up there and all that mumbling? Okay. Okay, so collaborative care for neurogenic shock. They did a really great job over here. We're basically going to do the spinal stability. Treat the hypotension and bradycardia. They even put this down over here for you somewhere. I heard them say it, the vasopressors and the atropine. Yep. So, with these guys, not as cautious as you would be with the cardiogenic shock patients, but with these guys, you're also going to be cautious with your fluids because a lot of times it's just that they've lost that systemic vascular resistance. They're not really low on fluids, but so you don't want to fluid overload them. And then make sure with these guys too are that poikilothermism, so we're making sure that we're monitoring them for the hypothermia. Which one? You can yell out your questions. I don't bite.
I was just asking, I missed the one where you said treatment for the hypertension and bradycardia.
With vasopressors and atropine. You're welcome. So the collaborative care for the anaphylaxis. Your drug therapy is going to be your epinephrine and your diphenhydramine. So basically your Benadryl, right? If they're still hypotensive 1 to 2 hours after you've given the epi and the diphenhydramine, then you will give IV corticosteroids. You also want to make sure that these guys are going to be just like your septic patients. You're going to be doing aggressive fluid resuscitation. So with the patent airway, you could be doing nebulized bronchodilators. Yep.
So they're not losing fluid. Why would we do aggressive fluid resuscitation?
Because it's hard to pull it back in. So basically, you're just resuscitating, and then they'll pee it out. Yeah. The nebulized bronchodilators, aerosolized epinephrine if they have that laryngeal edema. And if worse comes to worse,
You said aerosolized what?
epinephrine. Worst comes to worst, they might end up with an ET tube, right? Whatever we need to do to keep that airway patent. Remember that basically what it is it's just like a massive histamine cytokine release on the body's part. So you get everything third spacing, and until we can get the histamine and cytokines back where they need to be, like I said, it's going to be hard to pull it all back in. So so a big thing with these patients for prevention is patient teaching, right? So how can we prevent this from happening in the first place? We know that the next time you're exposed to bees, that you're gonna have this reaction, right? So we have to do lots of patient teaching. This is not a one-time thing. You have to have your own EpiPen to carry with you. Patient teaching about the expiration, how to use it.
Good luck on that. She's already.
So patient teaching is a big strategy in managing the anaphylactic shock, because I mean your patients, you see a lot of them that just keep coming back over and over because it keeps happening, and they're not. I mean, we had a few years ago, remember when the big thing was the EpiPens, all of a sudden they went from like a $20 copay to like $300 each, right? And then they finally figured out that you could just give them epinephrine in a syringe. And I really honestly don't even know what they cost right now at this minute, if they're back down. They are still?
Yeah.
Yeah. So it's hard. Sometimes you just keep seeing the same patients, and it's just, the patient teaching, maybe even of, that you're allergic to
Soy.
shellfish or soy or sesame seeds, and you keep going out for Chinese food. But I like it, and it tastes good.
Soy's in everything.
I know.
It changes my voice.
Does it?
Yes. So it's a little scary.
Yeah. Okay, so collaborative care for obstructive shock. Obviously, early recognition and treatment. Depending on what's going on with your patient, you could be doing, if it's a tamponade or a tension pneumothorax, you could be doing that decompression. So with a needle decompression, where you're either letting out the air or the blood from the tamponade. If it's a PE, they could be doing a thrombolytic therapy of some sort. If it's a mass, so sometimes they talked over here about the superior vena cava syndrome, and it's a mass basically pushing on the whole area, so you're getting that same blockage with the heart. You would basically have to do some sort of radiation to remove that mass. If it's the abdominal compartment syndrome, it's Cassandra, right? That you were asking about. So then they would go in and they would do like a decompression laparotomy. So basically, like, you know, they just go in through the little tiny holes and basically just decompress the abdomen. Mm-hmm. No, the paracentesis is going to be where they're going in and they're pulling actual fluid out. I mean, it depends. If there's fluid in there, then yeah, they'll be pulling out whatever is in there. But if it's just buildup of pressure, then it would just be releasing the pressure. So as far as your nursing assessment, same thing with everything, right? ABCs. So ABCs, vital signs, peripheral pulses, level of consciousness, cap refill, skin assessments. We want to make sure that we get a history, a good history of events that have happened recently. When, you know, the onset and duration of whatever symptoms it is that they come in with. You want to get a health history. What's their past medical history, past surgical history? What meds are they on? Are they vaccinated? Have they gotten any vaccines recently? Have they had any medications recently? Because it can be 4 to 6 weeks after certain medications that you actually have the reaction. If they have any known allergies, sometimes there are cross allergies. I threw just the nursing diagnoses up here that pretty much came right out of the book, the ones that the book recommended for these patients. So ineffective peripheral tissue perfusion, which is going to be every shock patient that you see, right? And it's going to be whatever peripheral tissue perfusion deficit that you're seeing, be it renal or cerebral, cardiopulmonary. Anxiety, potential complications, organ ischemia, or organ dysfunction. You guys know, so if you go into the Evolve online, I think that there's a link right in the course that'll bring you there. You have the student resources, like you have the resources for the 10th edition Lewis book, and if you don't, you should, I mean, it's free. You just have to go in and request it. But you go to student resources, it gives you the key points, it gives you case studies. One of the case studies, or one of the things that it used to have is the e-nursing care plan, and I'm pretty sure, oh, it is, because this is the 66. What's that? The e-nursing care plan. So I wrote down that, in 60 e-nursing care plan 66-1. So it's in your student resources. If you go in there, it'll bring up the entire care plan for like the nursing diagnoses and everything for these patients. So what about planning? What are our goals with these guys? Stabilize them. Well, yeah, we definitely want to patent airway, but our goals for discharge, say. So we want adequate tissue perfusion, right? Restoration of normal or baseline blood pressure. We want recovery or return of organ function. And we want to prevent complications due to secondary to prolonged hypoperfusion. We want no complications secondary to prolonged hypoperfusion. or avoid the complications. Evidence of adequate tissue perfusion. Normal or baseline blood pressure. Recovery of organ function. And no complications from the hypoperfusion. So again, your nursing implication is knowing your patients that are at risk, preventing sepsis, so making sure that you're washing your hands, that you're using strict aseptic technique, monitoring for subtle changes in your patients. So when we go through, I don't think I have slides for each one, do I now? So when we go through like neuro, if your patient's in shock, we're obviously going to be monitoring them. They're going to be in an ICU. We're going to be monitoring them at least once an hour. We're going to be charting it. That there are no changes in LOC, that there's no behavioral changes, that they're not confused. Urine output, that it's greater than 0.5 mLs per kilogram per hour. We're going to be charting that we're doing hygiene to make sure that we're keeping our patient clean and dry. So what happens with these patients if they're ventilated and they're laying in a bed and they're sweaty? They're going to have skin breakdown. It's going to happen super fast. So yeah, you're making sure that you're changing the sheets as needed, that you're getting pressure off. So maybe like, turning them every couple hours or every hour even. That you're doing range of motion exercises, active or passive, whatever they can do. That we're watching, they're all going to be on a telemetry strip, right? So we're watching for cardiac changes and trends, that we're checking cap refill and vital signs. We want to make sure that their temperature is being taken probably Q hour, if not, well, yeah, probably every hour. Skin, we want to make sure that we're watching temp and color, making sure that it's dry, making sure we're not seeing any of that mottling or diaphoresis. Make sure they have bowel sounds. They might have an NG tube to decompress the belly. They're probably going to be getting ABGs pretty regularly. RT will come in and do them. They might be vented. We're watching their O2, respiratory rate, breath sounds, work of breathing. If they're anxious or have that feeling of impending doom or just can't settle, we need to make sure that we're giving them something, medicating them, getting them clergy, getting family bedside, whatever's going to help calm them down, because we want to increase their oxygen need. Evaluation is going to be the same for everything, right? So we're looking at for cardiac, we're doing the ECG, blood pressure, CVP. We want it all within normal, temperature within normal. We want the skin warm and dry. Again, that urine output is the 0.5 mLs per kilogram per hour. Respirations, we want a regular respiratory rate in the SpO2 greater than 90. And we want them to verbalize if they are fearful or anxious so that we can deal with it. All right, so you have a patient in shock. The nurse recognizes the hemodynamics of shock include, can you guys read that? It's huge, right? do you think?
See? This is all types of shock.
Right, so it's D. So in cardiac output and cardiogenic shock is going to be low, not normal, right? Hypovolemic shock, which means that they don't have enough blood running through the pipes, so their CVP is going to be low. And the next one says increase in SVR in all types of shock. So remember, in neurogenic, anaphylactic, and septic shock, they're all going to be decreased. So the only one that really even makes sense is the last one, that we're going to have variations in cardiac output and decreased SVR in septic shock. The nurse is caring for a critically ill patient. They suspect that the patient has progressed beyond the compensatory stage. Oh, you guys don't need to know compensatory stages. Patient in septic shock. Which hemodynamic change would the nurse expect in septic shock?
See?
So it's D.
Oh, no.
It's D. You're going to have decreased EF, decreased MAP. When we talked about decreased CVP, most of the time we're going to see that in the hypovolemic or obstructive shocks. But we're always going to see SVR, the decreased systemic vascular resistance in septic shock. That's it. So is there